Becker from Ain Shams University. He's going to talk to us about surgery and infertility, what really helps. Please do.
Thank you very much for this kind introduction. Dear ladies and gentlemen, it's a great pleasure to be back in Cairo. And I do want to thank the organizers of this Congress, in particular Professor Gamal Surur and Professor Al-Shalakani, who've been good friends. I have 20 minutes, and if we can pull up the slides, I will get started. My talk is about surgery and infertility, what really helps. So what I will do is an overview. And for those of you who've been here for the first part of this great Congress, you'll find that this is a little bit of repetition, which I think is always good. So what are causes of infertility that are amenable to surgery? It's myomas, endometriosis, intrauterine pathology, tubal factor, and then no functional uterus, which has received a lot more attention recently. And these are the procedures that we would be considering: myomectomy, endometriosis surgery, operative hysteroscopy, tubal reconstruction, and uterine transplantation. Now, the big question obviously is, number one, what is the true effect on fertility of these pathologic factors? And that is disputed in all of them, except obviously for the fifth one. And then secondly, if we start treating, what is the true effect of the surgical treatment available? So let's start with myomas. And I'm particularly looking forward to Professor Jacques Donès, who's also here today, following up on this. So I will just give a brief overview. Generally speaking, and I think we all know this, myomas have only a minor effect on fertility. This publication goes back a long way, and it states that excluding all other factors, 2 to 3% of infertility patients are infertile because of myomas. If you look back in the 90s, people started looking at IVF cycles, 46 women with uterine myomas and versus 50 control patients. And actually, even at that time, they did not see a difference in implantation or pregnancy rates, unless, and that's the key point, unless the uterine cavity itself was distorted by the myomas. Of course, when we talk about myomas, and fertility, we have to keep in mind that there are other reasons to treat myomas. They can cause problems in pregnancy. So, there are many reasons why myomas should be treated: premature labor, IUGR, malpresentation. But we just simply look at infertility and uterine fibroids. There's a very good review article by my colleague and friend, Professor Grimbitsis, from Greece, 2016, and basically summarizing the available literature at that time. The statements that you should take home are: submucosal fibroids negatively affect fertility. Intramural fibroids that are bigger than 4 centimeters may negatively affect fertility, and subseral fibroids really have no effect. So in a meta-analysis by Pritz in 2009, there was actually no beneficial effect for the removal of intramural fibroids, but there was a significant beneficial effect for submucosal fibroids. So in this slide, we ask you to take just a brief look at this. We look at the type of myoma, submucosal. We look at the indication for surgical treatment. There's a significant impairment for reproductive potential. Effectiveness of surgical intervention has been proven. So the recommendation is hysteroscopic excision of submucosal fibroids. And then the other fibroids, intramural, greater than 4 centimeters, preferably laparoscopic excision. Intramural, less than 4 centimeters, expected management. So basically, if the fibroid doesn't affect the cavities less than 4 centimeters, we should probably leave it alone. And I'm looking forward to hear whether there's any new data on that. So again, greater than 4 centimeters, less than 4 centimeters. So I think this is something that we as clinicians can use almost on an everyday basis. 2017, there was a look at removal of fibroids in asymptomatic patients, patients who don't actually need the surgery except for fertility reasons. And again, this article summarizes the available scientific literature: no evidence that myomas reduce the likelihood of achieving pregnancy. So just because somebody wants to be pregnant but hasn't had any problems, doesn't mean you automatically have to remove fibroids. So fibroids should not be removed just because they are there, not even in a patient who plans to be pregnant. There is very clearly open or laparoscopic myomectomy for cavity distorted myomas. will improve pregnancy rate and reduce the risk of early pregnancy loss. That's been scientifically shown, and hysteroscopic myomectomy improves pregnancy rate. So everybody's looking at the same literature, and everybody's basically coming up with the same conclusions. Let's take a look at the summary statements, because we've talked a lot about evidence-based medicine. We all know that the evidence behind these statements is not very strong, simply because it's very hard to do prospective randomized trials in these settings. There's insufficient evidence that removal of subserosal fibroids improves fertility. There's fair evidence that myomectomy does not impair reproductive outcomes. Myomectomy by itself does not appear to be hurtful. There's fair evidence that hysteroscopic myomectomy for submucosal fibroids improves clinical pregnancy rate. So the recommendations right now, and I summarize: cavity dystortic myomas must be or should be removed. Non-cavity dystortic myomas do not remove except when clinically indicated. Let's move on from fibroids to intrauterine factors. Intrauterine factors are much more clear-cut. There's a really good article by my friend Keith Isaacson from 2019, Hysteroscopy, Why Macroscopic Uterine Factors Matter for Fertility. They look at a whole array of diagnoses that can be made by hysteroscopy. There's a big push by the AGL to be more open to doing hysteroscopy in all patients that have fertility problems or any kind of uterine problems. They call it the stethoscope for the uterus. I think we keep that in mind. Some of these issues can be treated by surgery: polyps, synechia, and of course, Müllerian anomalies, mostly the septum. So there's little doubt and discussion about the treatment of polyps and synechia with regard to symptoms and fertility. Interestingly, in 2017, there was a Cochrane review on septum resection for women of reproductive age with a septate uterus. Now, a lot of that is actually done, and the Cochrane review caused quite a stir, because they say at present there's no evidence to support the surgical procedure of this woman. Now, we know Cochrane is very strict, and some of the evidence that we as clinicians would accept is rejected by Cochrane. However, there was a big, almost prospective study, not quite, in 2020 from a group of Dutch colleagues. And first of all, 0.5 to 2% of women do have a septate uterus, so this is not a small number. And this is the result of this study, and I'll show you the detailed numbers. What you can see is that there was no difference looking at the live birth rate between the group of patients that underwent septum resection and the group of patients that did not undergo septum resection. The study caused a great stir amongst hysteroscopic surgeons, and there's been a debate going on. Let's take a brief look at this study. 257 women, 151 received a septum resection, 106 received expected management, and the follow-up was 46 months. 53% live birth after resection versus 71% live birth after expected management. 46% pregnancy loss after resection, 34% pregnancy loss after expected management. 29% preterm birth after resection, 16% preterm birth after expectant. So it's a very clear statement. And 19% malpresentation after resection, 34% malpresentation. So the only advantage of septum resection is that it appears to reduce malpresentation. Now, the authors of the article conclude that it does not lead to improved reproductive outcomes. However, they also are very critical about their own data. So this is an interesting study. We'll have to see how the literature evolves. Let's briefly talk about endometriosis. We have heard a lot about this, so I think what I'm going to do is just summarize what you already know. There's a very interesting Cochrane review on overview on endometriosis, 2014. There hasn't been an update since, and they look at 8 reported fertility outcomes. Interventions effective for infertility and endometriosis. ART is in fact effective. There's no question about that. Second point already is surgery. Excisional surgery improves spontaneous pregnancy rates 9 to 12 months after surgery versus ablative surgery. And I think we've heard that from our colleagues this morning. Laparoscopic surgery improved live birth and pregnancy rates compared to diagnostic laparoscopy alone. Now, these are very general statements, we know that endometriosis is a very individual disease. So with this, armed with this knowledge, we have to make very individualized decisions based on age, symptoms, extent of disease, and obviously this would be a whole lecture on itself. There's no evidence that medical treatment improves endometriosis, which makes sense since most medical treatment is actually almost contraceptive. Treat the symptoms, not the disease. Endometriosis is a fascinating disease. And for those of you who are interested, I have another lecture on endometriosis, and I'll give you my email address at the end. So these are just summaries on how we treat endometriosis in Frankfurt. Now, of particular interest are endometriomas. There's a great and not quite yet published article, 2021, mentioning endometrioma to optimize future fertility. So you can see this is of great interest. And basically, what they're saying is it's hard to distinguish what is more detrimental, the endometrioma or the surgery. What they do stress is that the bad surgeon is always detrimental. We've heard about the technique of excisional surgery for endometriomas, and endometrioma surgery is often treated as easy surgery. But once you realize you can severely impair the fertility of a patient, particularly in bilateral endometriomas, you also have to realize that, as always, when you talk about surgery, the quality and the experience of the individual surgeon makes a big difference for the patient, and in this case, for the ovarian reserve of the patient. Now, this is a little bit small. I'm not sure whether you can actually see it. The key distinguishing factor here, and again, I'm happy to send this out, is that in somebody, this is endometrioma trying to conceive now. First approach is you can probably wait, but the second approach is you look at age, older than 35 years, less than 35 years. And then you look at the size, if the endometrioma is smaller or if it's bigger than 4 centimeters. So you can see here in patients who are less than 35 years and who have big endometriomas, surgery is the preferred way. So again, just like in myomas, in endometriomas, the age, the expected ovarian reserve, and the size of the endometrioma will serve as a distinguishing factor. If endometrioma surgery is performed, cystectomy, and we've heard that this morning, is better than excisional, by excisional surgery is the most effective way, and it's better than cyst drainage or ablation of the cyst. Very, very important. Recurrence rates are 16 to 50%. We've heard endometriosis is a chronic disease. Repeat surgery is even more dangerous than the initial surgery. It can lead to a postmenopausal situation in your patient if you're not very careful. And even more importantly, the available data does not show that repeat surgery improves fertility outcomes, which means that if you treat endometriomas, you need to have the fertility of the patient in mind, because you do not want to go back 2 years later and retreat the endometriomas, and the patient has not resolved her fertility issues in the meantime. And we have to say ART and IVF are much better than endometriosis, than surgery, particularly in an asymptomatic patient with a small endometrioma. So I think we're moving away from the automatic removal of endometrioma. We really look at the symptoms. I only have one slide on the tubal factor because this has been discussed many times. Tubal reconstructive surgery still exists in selected cases. There are very few centers who still do it. The success rate in the literature is 50-50, highly dependent on the surgeon. It does open a non-time limited option, meaning IVF can only be done once, not twice. And we've already heard, and we know that Professor Suru has been particularly forceful advocate of the problems for couples who don't have the financial means. The advantage of this technique, the only advantage really, is that it's an open-ended technique. So IVF obviously has most to replace tubal surgery. I'm going to conclude talking about the newest advances for infertility, no functional uterus. And up until 5 years ago, we've accepted that as a fate, with the only possible solutions being surrogate motherhood. But this is probably the area where most changes have been taking place. And there's an excellent review article by Mats Brandström, who, as you know, led the Swedish group who first scientifically proved that uterine transplantation with subsequent childbirth is actually possible. So they summarize what has been done so far, and so far there have been 80 uterine transplantations worldwide, resulting in more than 40 births, and this is exclusively cases documented in the literature. In summary, 62 transplantations have been written up. 50% success rate, with meaning there's a menstrual pattern, so this appears to be functioning uterus. Live donor 78%, deceased donor 64%. Now, this is major surgery. So the serious surgical complications of the live donor are 18%, and in the recipients 19%. So we're talking about a major surgical intervention. Cumulative birth rate has been 80% after a successful transplant. So if the transplant is successful, which it is in about 75%, then you achieve a pregnancy rate involving IVF, of course, in 80%. All in all, 24 births have been reported from different countries, including Sweden, the United States, India, Brazil, Germany also. There's a high rate of preterm birth, but generally these pregnancies can be managed. It's important to remember that the incidence of no uterus is not low. It's 1 in 500 women. So it's much more common than we generally think. And particularly for my colleagues in the United States, where there's a huge African American community, I know that uterine myomas in that particular community often lead to hysterectomy. So I originally thought this was a procedure exclusively for Mayer-Rokitansky Küster-Hauser patients with vaginal aplasia, but it appears that in different areas, this might actually be an option for women who have the classic uterus, who are 32 years or 35 years old, have classic uterus, which we know will not be able to carry pregnancy. So with this, I conclude. Prospective trials continue to be called for, but it's a little bit questionable whether many of these trials are feasible, and if they are feasible, whether the results are really valid. Decisions so far must be based on the clinical knowledge and studies, medical judgment, which I've tried to present. I summarize: submucous fibroids should be removed. Other fibroids do not affect pregnancy as much. Endometriomas should not be removed for fertility. Laparoscopic resection of other endometriosis improves fertility, but does not improve ART outcomes. Particularly for this audience, I want to stress you have to distinguish between the surgical effects on spontaneous fertility and on ART fertility. Intrauterine pathologies should be removed. However, hysteroscopic septum resection remains controversial. Intrauterine pathologies become more significant after a history of pregnancy loss and failed implantation. Tubal surgery is clearly the second choice, and uterine transplantation will become a semi-routine procedure. And with this, I